pelvic PT can help with lots of different kinds of pain. The interesting thing about pelvic pain conditions and the titles of them is some pain conditions are named for the activity that hurts. Some pain conditions are named for the anatomical location of what hurts. And then some pain conditions are named after like the pathology, the medical cause of what's going on. So it can be pretty easy to rack up like 3 different diagnoses, and it doesn't really always mean you have 3 separate problems. So I'm going to elaborate a little bit on a couple terms. So pelvic floor dysfunction is probably the most general term that has to do with pelvic floor pain. It basically just means your pelvic floor hurts. Sometimes people will get a diagnosis or come in with a diagnosis of pelvic floor dysfunction, thinking that sort of determines their treatment program, but there's so much we still don't know, with or without the title. For more specific titles, there's vulvodynia, which if you were to kind of look at the pelvic floor and imagine like those 2 soft pieces of skin of the labia, vulvodynia would mean that this whole area of tissue, even like the outside of it, is painful. And then you have what's called vestibulodynia. So the vestibule is this kind of light pink opening of the vaginal canal. So if it's pain specifically here, that one's called vestibulodynia. And then you have what's called vaginismus. So very similar area to what we're talking about, but basically you've got layers of your pelvic floor. This is that more external, more superficial layer. If you were to look deep inside, that kind of deep, more like beefy, thick hammock layer, that's your deep pelvic floor, or the levator ani you might hear. So vaginismus is when the muscles that are on the outside here, this more external part of your pelvic floor, tightens up anytime you try to insert something. So oftentimes the symptoms might be like pain with inserting a tampon, or pain with intercourse, or pain with a speculum at the doctor's visit. But you can kind of see how if somebody has pain with insertion, they might be labeled as someone with vestibulodynia because yes, this area hurts. Their muscles on the outside also might be tightening up, so that kind of also meets the definition for vaginismus. It definitely meets the definition for pelvic floor dysfunction. So this doesn't mean a million separate issues are going on. It just means there's lots of ways to describe pelvic floor dysfunction, whether it's a diagnosis or it's not. When you come in to treat your pelvic floor condition, what I'm looking at with you is I want to hear when your symptoms hurt, what they feel like, where they are, and then when I take a look, I want to press in to all these areas, see if they're moving well, hear from you, does it recreate any of your pain? And then that gives me a lot of clues as to how to narrow my focus on the specific things that are gonna help you. And then we're also going to check for, is your pain deep in here, this levator ani, or is your pain only on the outside? Is your pain at all the whole pelvic floor, all the levels of it? Does your pain travel behind the hip? Do you have a scar that you can feel when I press on your pelvic floor? That lets us know areas that are not happy, not probably getting great blood flow, and nerve pathways that are sensitized. So that's really important information for us as we go ahead and treat your pelvic pain. So let's work our way through a couple more pelvic floor conditions as well. So interstitial cystitis, that's one that I see pretty frequently. Pain or discomfort with the feeling of bladder filling, or pain that is perceived to be coming from the bladder. So the key with perceived to come from the bladder means a lot of the time it doesn't come from the bladder. A lot of the time it comes from your muscles. So with something like interstitial cystitis, I'm checking out, again, both layers of your pelvic floor. I want to know what's the status of those. Is this a part of your pain? Is this contributing to something that makes you feel that urgency or urinary pain? Also, I'm checking out your sciatic nerve. So just like an orthopedic therapist, I need to know about your back, and is that contributing to anything you're feeling in here? So that's like a really, really brief, simple description of kind of what I'm looking at and thinking about as I start working with somebody that has IC, interstitial cystitis, painful bladder syndrome, which those terms are effectively merged. They are the exact same thing, whichever one you use. And then also there's the condition genitourinary syndrome of menopause. So that one is caused specifically by low hormones to this area. The tissues of your vaginal opening, bladder, urethra, they all need to bind to hormones and work with hormones in order to be healthy. So when our hormones really dip, which can be perimenopause, postmenopause, it can be due to birth control or maybe another medical treatment that's changing your hormones as well, that can all create actually those same symptoms of IC. So famously, urinary urgency, vaginal dryness, pelvic pain, wherever that pain is. A lot of the time it'll be like the sit bone in the bladder, or it'll be the pubic area in general, or it will have to do also with their tailbone. There's no limit to these things that can become connected in somebody that's got pain. GSM and interstitial cystitis or painful bladder syndrome, if you made a list of symptoms of both of them, they'd be the same list. You can have all the same symptoms for both those things. So again, it's not always the most important thing what we call something, but it does give us a little bit of clues as to how we can start helping and what we find, and basically how it makes you feel. As we release something, what happens to your pain then? That kind of stuff can give us a lot more clues. Now, then you have certain pain conditions that actually are a physical medical pathology. Pelvic floor treatment is still really important because the pelvic floor sitting underneath the organs in your pelvis, so bladder, uterus, rectum, your pelvic floor has a lot of reflex connections with all those organs, and those organs have a lot of reflex connections to your pelvic floor. So say somebody has something like endometriosis. So if you take a physical, medical, pathological type of diagnosis, you can think of endometriosis. That's where a tissue that is histologically, when they look at it in the lab, it's very similar to the lining of the uterus, and that tissue is found outside of the uterus. So it can be on pelvic organs, which it often is. It can be really actually anywhere inside the cavity of your torso. So what that tissue does is it causes inflammation, it causes pain, it makes its own blood flow. So unfortunately, it cyclically can evolve month to month with your menstrual cycles, just like the lining of your uterus would. And then very often it will have components with it like back pain or other pelvic floor dysfunction, like maybe urinary urgency or leakage or painful intercourse or tailbone pain. So the whole list of things. People with endometriosis all present super differently. So having endo gives me a really good direction, and it helps me help you manage your whole care plan. However, what we're going to treat in PT depends on you and your pelvic floor and how you feel as you move. So treatment will still be individualized. A lot of the time with these pain conditions, we will focus quite a bit on myofascial mobilization. Sometimes we're doing other things to complement that too, like expanding the pelvic floor, working on pelvic floor, hip mobility, back mobility. It just depends on what we find. And then you have other conditions like maybe fibroids. If somebody's got a history of fibroids and maybe they just had myomectomy, which is surgical removal of those fibroids, or those lesions that kind of sit like on the uterus and in and around those organs. Anytime we have surgery, we're gonna have scar tissue. So pretty much what we're treating at that point after the problem of the fibroids is removed from the equation. We want to make sure your layers of tissue can slide and glide against each other in a functional, effective, and pain-free way. So we might be mobilizing some of those organs, we might be mobilizing tissue over those organs, we might be mobilizing tissue over the incisions, or we might be mobilizing the pelvic floor because over time of dealing with those fibroids, the pelvic floor has responded to that by clenching, trying to protect you from pain, which in turn usually leads to more pain. So treatment with physical therapy can be pretty important even if your condition is one of those gynecological conditions that has resulted in muscle issues downstream. And then you have diagnoses like dyspareunia. So dyspareunia means painful intercourse. That diagnosis really just is about the activity that hurts. It actually doesn't really tell you, again, is it because of endo? Is it because of IC? Is it because of pelvic floor dysfunction? Is it because of vestibulodynia? Like, that doesn't really answer any of those questions. It just tells you what you know, that you have pain with intercourse. There is superficial dyspareunia, which here's where we're talking about this more outer layer. There's deep dyspareunia where you're feeling it more from this side, and then you certainly can have both overlapping as well. So when you come in on your exam, we'll talk through your symptoms, and then I want to also feel the muscles, feel how they're moving, and hear from you how you feel with a little bit of pressure, movement, mobilizing the areas around them maybe as well. And then another common one can be tailbone pain. So this bone here that sits at the very, very end of your spine. Sometimes people really do have tailbone pain. Sometimes people have a history of fracturing the tailbone or falling on the tailbone, and it can have pain there. But the other really interesting thing about the end of the tailbone is when your spinal cord ends more like up in the lumbar spine here, it has connective tissue that goes and travels down the front of your spine, and it anchors right on the tip of that tailbone. So very, very often people who have pelvic pain feel tailbone pain because there's pain at the tailbone. But sometimes if you make their nerves happier, you give more blood flow to bigger nerves like the sciatic nerve or other nerves that also come out of this area. We mobilize the tissue, the ligaments, the things that are around the back of the pelvis. Sometimes that actually fixes the tailbone pain. So again, that's a case where the pain is named after anatomically where it is, doesn't really tell you how it got there or what needs to be done about it. So pelvic pain can be pretty complex sometimes in figuring out where things come from. We don't always figure out 100% of the answers in just the first day or the first conversation, but that again highlights the importance of really having that individual assessment so that we can get some information. Yeah, you could have one thing going on and it checks the box for being considered pelvic floor dysfunction because something hurts, so your muscles are tight. You can have vulvodynia because this area is tight and it hurts to insert. You could call something tailbone pain because, hey, the pelvic floor is dysfunctional. Now it's pulling on the end of that tailbone and the nervous tissues that attach to that. So you can not necessarily have a million things going on. You might have one thing going on, but it meets all of these terms. So it's nothing to freak out over or stress out over or think one doctor gave you wrong information or something like that. These are just titles that sometimes help guide care and sometimes they don't. So it's nothing to really get super worked up about. What you're feeling is the most important part of it, but will help you manage any of these diagnoses. The most important things when you have pelvic pain is talking to providers that have a lot of experience with pelvic pain. Believe it or not, that's easier said than done. So for example, if you're talking to like your OB-GYN, right? OB/GYN, if most of their job is delivering babies and you kind of have this like complex pain that is kind of difficult to explain, and it changes and it moves from place to place, and it's with certain activities sometimes, but not other times. Sometimes they're really good at screening and helping you get to the right place. Other times you might feel like you don't get answered. So I would say the important thing is share all of your symptoms and maybe even track them if you're not sure if maybe there's a pattern with them. I would connect with a pelvic PT for sure, because pain is what we do, but I would also share these symptoms with your medical provider, because if there is suspicion for fibroids or endometriosis or something that is medically not supposed to be going on, you do want to make sure you're following up and making sure. But PT should not be left out of any treatment for anything that has to do with pain, because we're the pain people.